Well, thank you so much. I appreciate the introduction. Thank you, everyone, for taking some time on your Wednesday to spend with us and to share a bit of the journey, the story that I've had, and how I think really transformatively accelerated part of my practice to allow me to, make my iPhone even better and really become a better teacher, better clinician, make quicker decisions, and especially, times of essence to make everything just more fluent. So titled Wireless Handheld Ultrasound in Urology, which I think is quite fitting for urologists with regards to what we were taught. And you look back in sort of the Campbell's Urology, the art of uroscopy, just looking with a flexible lens into or even a rigid lens back in the time, to what that was the founding portions of urology, to now the practice that we run now with PSMA and molecular biology and so forth. Our current practice is very much unrecognizable to what was first started off urology. So I think urology and ultrasound in urology is something that's already we're very familiar with, reading our own images, ordering special tests, certainly from the kidneys down to the phallus. All that soft tissue can be evaluated. And to me, this ultrasound is just really an extension of the physical exam. It's safe. There's no radiation. It's real time, and we can interpret that and demonstrate and show our patients, be it us or even in the emergency room. I think that just adds to the experience and the trust and for really the quick interpretation to allow faster delivery of care. Certainly, when I first got interested in this and reached out to the AUA, they had these hands-on courses because exactly that. We don't really have formation during our training. We learned how to, fill out a prescription pad and send it off, and we send our patient to get their imaging, which adds time, complexity, and certainly now post-COVID, a certain level of difficulty, especially for our elderly patients. So there's these hands-on courses. I said, look, let me get involved. Pat Fulgham said, come on down, we'll spend some time, and there's a formal process, and these sell out. I mean, it still continue to sell out because there's a great demand, and to which I think, it just allows us to become better clinicians. You can add to your more comprehensive examination. And certainly in certain parts of the world, this is something that's a billable event, and that you can, add to revenue aspects for the practice. Urology, soft tissue. I mean, we're not doing in the brain, we're down below from the kidneys and the retroperitoneum. We got the abdominal, liver, kidney. You can see if there's hydronephrosis. We'll cover some of these things in the following slides. In the pelvis, we have the bladder, the prostate for males, the scrotal exam, soft tissue, and certainly penile. It's another area that for erectile dysfunction, Peyronie's, which is, again, great value in measuring, assessing, counseling, seeing differences for our patients. And I think, just the ultrasound is going to continue to grow, be it from HIFU, ultrasound therapeutics, to fusion biopsies, which, again, transferring from transrectal to transperineal, and perhaps even using AI targeting for the future, but at least now MRI guided. And I think with SpaceOAR for protection for rectal wall injury. And then we'll see down the road, I think, some of these contrast enhanced ultrasounds or micro ultrasounds, which are just phenomenal in terms of 29 megahertz, which are even competing with some of the accuracy of multiparametric MRI. So growing up as a resident at McGill, that's an ultrasound. It's this, 100,000 plus device that requires to be plugged in. It weighs a ton. You got to wheel it around, or the patient has to come to that room to be examined. Again, they're large, they're expensive, they're wired. There's paper or not. So these are all aspects. There's so many buttons, part of the knobology of learning these, which, again, it's very great technology, but it's not something that's very practical for especially urologists. If you're a resident, you're running around in the emergency room, you're in the ICU, you got called to the floor, it's 3 a.m, you get it. So you need something that's gonna be wireless, it's gonna be portable. And if we can, what screen does everyone have? Well, you got the iPhone or your mobile provider, for Androids. And that's what's cool, is that this now is a cool device that from month to month you get, new updates that you can make like a Tesla. You've got the best model, but you want something that's small, light, portable, that's going to be this sort of point of care. So the delivery is wherever you want it to be. It's in the woods, your backyard, the emergency room, in the car. I mean, you can take this anywhere. This now competes to something smaller than my iPhone. And it turns my iPhone into a teaching tool. So that's it. So, there are a few other companies that have tried out the GE, I've tried the Butterfly, and at least what I loved about Clarius, aside from being Canadian made, is that they have different profiles. So you can have the C3, which is the one we'll show most. And I think from urology, if there's one that is the tool for all, it's the C3. It's got a maximal depth of 40 centimeters. The frequencies between 2 and 6 megahertz. There's also the unique, the one and only endocavity. So for gynecology, urogyne, or urology looking to do diagnostic or therapeutic, we'll dive into that. But it's a very great tool and has specialized sheaths on the side that allow for needle track or biopsies. So that's something else to consider. And then you have the L15, the linear, which is a great tool if you're using, if you're big into the penile Doppler, great accuracy, better frequencies for that for linear. But again, all three can be purchased, and I think all three lend itself for urological practice. So the one and all, like kind of my stethoscope, which somewhere on my wall here I have, which I barely use and doesn't really add much to my practice. This has become the stethoscope to allow me to assess the kidneys for hydronephrosis or renal cyst, or if there's a mass to follow, or post RFA to see if there's a scar. And I can do that myself. And again, it's just something so simple to check the bladder, PVR. So certain patients, if you need to check the bladder scan, and in the Canadian system, our bladder scans are like, $10,000 or $12,000 by one company, whereas this handheld device of 6,000 or 7,000 can do that and so much more. So cost economically, it's great. And they now have this AI, which we'll demonstrate later, where you literally just need to press one button, it scans and does it for you and reports that. So you don't need a lot of skill set to do that. So I'll go through some of my BPH practice where, picking up bladder diverticulum, bladder stones. With LUTS, you can pick up bladder tumors. Is it vascularized? Well, guess what? I can throw on Doppler. There's so many cool technologies built into this device and the software. It's quite impressive. The linear, again, for penile Doppler, so men with ED, Peyronie's, plaques, if you're looking to do injections with Xiaflex or calcium channel blockers or what have you, great tool. For scrotum, if you're, see someone in the office with an acute scrotum, you want to know, is it a hydrocele, a hernia, what have you, very easy to do. And picking up any kind of testicular lesions. And then finally, the EC7, which, it's a great tool for your measuring your trusses, prostate volume, especially in certain obese patients, where you may not get that contour through the transabdominal approach. Picking up seminal vesicles if someone has infertility issues. Again, could be used endovaginally as well for cysts, prolapse, or what have you, for urogynecology. So we'll dive into that and some of the really cool options of using this for biopsies and for those looking to do MISTs, such as Resume or Optilume or iTin, where you want to get a block. You can do this very nicely and keep your eyes on focus, and we'll cover that with a video. So I just think that, to me, this is just an extension of the physical exam. I went as a tour with the EAU CUA exchange program, and here I am visiting different European countries, and this is part of their practice. Everyone had this in Germany. Everyone had this in Leuven. So it was just coming back to see, wow, this is something that's just standard of care across Europe. So to me, just really, it takes our 5 senses and this for urologists to a new level, because it's not a great tool. So it's something that can be transportable, fits in your bag and has a very good battery life to last you through the day, at least for my practice. In the emerge, in the clinic, in cystoscopy, and is my catheter in the right spot? Operative theater, we want to see if the double J's up. You can do that in a pregnant patient. Teaching, education. So there's built into the software that you can have a conference call and show the images, or capture a video, capture images, and either, to the cloud, print it up. We'll give it as a medical file to the EMR, or share it with the residents, or share it with the patient. Getting that second opinion, we see something that's abnormal, my other colleague signs up on Clarius app and he sees exactly what I'm seeing real time. And again, some of those advanced softwares, which again, we didn't speak much of, there's B-Wave, the gray scale, but we can throw on Doppler. We can check elastography. We can look at power Doppler for vascular flow. So again, great tools, very helpful and built in. So it's not like you need to buy this and there's up programs. This comes with the software. So since 2016, I've done quite a few. I've got a few scanners, and again, this is something that just a testament of the facility, and it doesn't take much. It adds maybe 2 to 3 minutes more per my visit. But what my patients look at me, they're like, wow, that's on your phone. There's just such an excitement that you can see inside me, and that's your phone. So again, it just builds that trust. And, to those starting up in their young practices, is that important to you that your patients, see and believe and kind of feel that you're a leader in increasing technology and delivering better care. So again, this is what the printout, you can go on their cloud. It's built into the your purchase with the device, that you have cloud access that you can click. And to those on the line who are urologists, they'll laugh when I say this, but you're doing your prostate check and the patient looks over, hey doc, is it bigger? And you're kind of thinking in your mind, I don't remember who you are and I don't remember what that felt like last, but quickly I can show, get that printout. But last year you're 41, this year you're 47 grams. We know BPH can grow 2 to 3% per year from the Olmsted, from some of the longitudinal studies. So yeah, you can look back and say, yeah, you were this size, now you're this size. We do it for our kids, right? You stand behind the wall, you put a little pencil and look, you're growing. But it's an organ which patients don't know. And unfortunately, these grow. And I think sometimes as urologists, we fail identifying those who are going to progress toward retention and only get to them when they have deteriorated bladders or retention. So again, nice tool, longitudinal assessments, and then we can answer the patient when they look behind and say, hey, did it grow? Give me a second, click, and there you go. You can see the differences in change. And that also correlates nicely with PSA density, which again, as urologists, we encounter a lot of those elevated PSAs, but for a guy with a 300-gram prostate, that may be a part of why it's a PSA of 5 or so. Again, let's go through the systems top to bottom. So we look at the kidneys, beautiful way we can just check cortical wall thickness. We can see if there's any cysts or mass. If there is, questions of vascularity, if there's trauma, you can pick up vascular flow or ureteric jets in the bladder if we were concerned of obstruction. And certainly any kind of thickening of the walls, be it the ureter or the collecting system. And, just as what it looks like. So you simply apply this to the abdomen with some gel or any kind of liquid interface. I find sometimes the COVID hand soap alcohol just as good and helps clean everything up and doesn't get too gooey. And simply just, applying that to the abdomen, and we'll see here just, rotating and fanning. And these are some of the skill sets that can be picked up and learned. And I know that Clarius also has a good training program and online modules. So we'll just jump ahead here. So, the normal findings of a kidney depends on the age, the sex, if there's any previous treatments, what have you, but between 8 and 13 centimeters in length. We want to see that nice cortical wall thickness, or kind of like the steak of the kidney. That's the filtering nephron power. And you want to assess the cortical, the pyramids to assess to see if there's any hydronephrosis. So you can measure that length and you can basically see with, I think, very nice accuracy, the hypoechoic nature of the contour of the cortex. And then that central fat, you'll see more white, much more hyperechoic. Or if you find an AML with, angiomyolipoma, the fat content, similarly, you'll see that whitest tissue. And you can use that in the two senses, the sagittal and longitudinal views. And then sometimes you'll pick up some mild hydro, someone who just recently passed a stone, or you just removed the double J, or you've deobstructed and you want to see how things are going. Well, there you go. You can pick up some, from some mild to moderate. So, just simply just a little video to get a sense of what that looks like. And it's real time. There's no lag. It's impressive. And, you can just show that to the patient, capture video. It's up to 30-second little segments, and even pictures sequentially, and really no limit. And the severe cases where you may see some chronic, and this is a patient with like a UPJ obstruction and narrowing of the pelvis, draining the kidney, and you can see some thinning of the cortex because of the chronic nature of the obstruction. And that's just some sagittal views here again. So just to show, what that would look like. And, you know, for those who are urologists are like, yeah, I picked that up back in pediatric days with reflux disease, but yes, I think that's pretty obvious to pick up, and it's quite nice that the accuracy that you can pick that up. You know, this is a case that I had seen for a left renal mass, and so, you know, just some images of the liver you can see in the longitudinal view in the mid, and then finally on the far right you can pick up this heterogeneous mass, solid in nature, and on Doppler did have blood flow. So again, for sure, I'm going to send the patient off for a CT, but I've already engaged in the discussion. This is most likely what we're going to see. It's a vascular type of mass. Get the ball rolling. So, you know, that expedites things, and I think just allows for a lot of less anxiety. I think, unfortunately, patients are left sometimes in bewildered modes, and not knowing is sometimes worse than, you know, our anxiety post-COVID brains take us to dangerous, dark places. So as a physician, if I can cut that out and help patients have a better experience, get treatments earlier, why not? So again, here's the next, jumping to the scrotum, looking at a scrotal mass evaluation. And, you know, someone comes in with a scrotal mass and you examine them, and you can do a transillumination. You can feel it's circular. Is this bowel? Is this hydrocele? Is it septated? So normally would write the script, they go, maybe a month or two later, they come back, and who are you again? Oh yeah, okay. So there's that unpleasantry and colossal waste of time for both the patient and the physician. So right there, you can look and examine, pick up, hey, this is only above the testicle, it's a spermatocele, it's circumferential around the testicle, it's a hydrocele. Is it septated? Can we drain it? We can measure it. Or is it a hernia? And I'm going to send them off to another physician who specializes in that. Here's a case of an acute scrotum, someone who was punched and had a testicular fracture, which we saw as well, and had a large hematocele. So again, something else that can be nicely added to the evaluation and save time as we proceed to the OR. Next up, you know, sort of the testis mass. So someone with an intratesticular mass, you know, where you're worried it's a torsion, or you worried there's some kind of a cancer. So again, you're in the clinic, you can pick up this is an intratesticular mass. So rather than sending the young gentleman off to go get his ultrasound, then come back, then engage in discussion, look, let's go get the markers, set him off for a CT. You know, if you want to send an ultrasound too, but at least you've engaged in the discussion and the treatment and save time for this young gentleman.
Some of these applications seem really useful to bring in if you're on a call to emergency, you know, instead of waiting for the radiology to perform scan, if the, you know, emergent decisions need to be made, to bring it in with you. Do you ever use it in that application?
Yes, I mean, again, some emergency people, and maybe you're in the same situation, but none of my emergency people have ever seen that. So they come to me like I've just been beamed down from Star Trek, and they're like, what is this? Where is this? And so they have some of their, you know, crash trauma ones. They're looking for blood under the liver for acute abdomen, but to get to that granular level, again, I just think that's a lack of knowledge, lack of access of resources. And again, so I think I'd like to see that. My dream is that, you know, every urologist should learn how to get one of these and learn how to use it. It's, you know, if you have a stethoscope, which is probably like mine, sitting on a wall, you know, maybe listening for bowel sounds, it's not a very, and half the time you leave it somewhere and you have to, where did I put it? And you forget it half the time. So this to me is just a great tool. And yes, it has helped in some of those discussions with Emerge to counsel and move things along. So I'm not saying I want to take over the job of the radiologist, but certainly just, I'm a physician, I have clinical judgment, I suspect certain things, and I can guide and feel more confident in that direction and move things along. And I think the patients appreciate it. Next up, we'll just talk about some of the penile access. So I think for Doppler, when you're working up someone with what you believe is vasculogenic erectile dysfunction, or in this case, a patient with some Peyronie's with a plaque, you can assess. Normally we kind of people writes their notes with a plaque and they kind of grade it or its size. But here we can measure its thickness. Is there some underlying spongiofibrosis? And we can look at that arterial flow on Doppler. So that's what that would look like. You simply bring over the pattern over, and you can pick up whether or not there's significant blood flow. You can do the power Doppler and measure resistive index as well. So for those who are interested in some of the erectile dysfunction applications, they are all, again, possible with Clarius. Moving to my neck of the woods, what I use this almost, on every patient, assessing bladder and prostate. Really, I think that there's a huge evaluation, which sometimes is missing in the details. So my colleagues in the past would just write, on a cysto normal. Well, what about the bladder wall? We know with BPH, there's thickening of the bladder, there's hypertrophy as compensation. We'll pick up that, and I think that's some of the earlier signs that we have obstruction is compensatory bladder wall hypertrophy. We can pick up other types of BPH-specific disease, such as bladder stones, whether or not there's a middle lobe, intraprostatic protrusion, diverticulum. And again, it just sort of helps us not just the diagnosis, but the treatment. As for those who are on the broadcast, if there's treatments, if you're a 95-gram or a 25-gram prostate, there's different treatments that are emerging or currently available that are based on volume of the prostate and the presence or absence of a middle lobe. And finally, as I said, it really allows us to give us some interval changes. So we all see the PSAs, but does anyone ever kind of ask a 40-year-old, a 45, a 50-year-old, what's your prostate size? Are you a grower, or are you just a slow evolver? And there's going to be guys, every man on this phone here, at some point when you're 18, your prostate's maybe 20 grams, but some patients' prostates are 200, 300 grams. They weren't born like that, but we missed the boat on catching them as they're flying off the scale and perhaps offering treatments or getting them earlier in their disease process to avoid the hydronephrosis, the renal failure, the infection, and the we call it benign prostatic hyperplasia, but BPH is not benign. There's a lot of, costly and potentially dangerous things that can happen out of that. So again, this is simply the patient's on the table, they've done their uroflow, they come on in, and simply we'll lay this on the belly, and I'll assess their PVR, and then I'll immediately go and look and zoom into the bottom of the bladder, where you'll see yes or no, there's a middle lobe. And from there, assess the echogenicities, as there's lots of calcium stones at the capsule. Are there cysts within the prostate? See if there's any hypoechoic areas in the peripheral zone. I'll measure the X times Y times Z, and really you can see I'm two-handed. I don't need knobs. I'm simply just inflow of what I'm normally doing. You don't need much different position or extra equipment. I'll bring up and be able to do pictograms. Is the left or the right side. I'll measure the bladder wall thickness. And from that point, move my way down to the prostate and do the X times Y times Z, which is already built in. So I don't need to sit there and use a calculator at the end. This is naturally done in the app. And to which at the very end, it'll help generate a report that you can either import digitally to the EMR or print it out for your records, or print it out and give one to the patient. So now they've take this home and they say, wow, what a great doctor this guy is, or she is, that she helped me identify where I'm at, and do this annually to see what their growth is. So get them involved, get them to be taught what's happening. And really, you don't need a big skill set to do this. And I've done this on large patients and various size patients. And again, there's not much in the way except for the pubic bone. And that may be the only thing where you may need to deflect down to see that apex. But really, the big key thing is that the bladder neck, is there a middle lobe? So I'll go ahead and jump ahead here. Again, hematuria workup for a gentleman who also had LUTS. And, we can pick up the ureteric jets, and you can see on the far left, those images of that sessile bladder tumor. It's a tumor, I wouldn't say it's too sessile, but it's a bladder tumor. So kind of knowing before cysto, I've got a tumor on the patient's right side, and it looks like it's going to be far away from the ureteric jet. So, already in my mind processing what I'm going to find out, the things I'm going to want to look for in more detail, if there's any associated CIS or secondary tumors. So again, that's a nice little tool that simply adds on another 2 minutes to the exam, giving you more information, which as surgeons or as clinicians, the more information, the better. And I think part of our EMR stress and overload and burnout is we're scavengers. We spend time trying to hunt down a creatinine. Oh, I got to click on this system, and oh, what's the CT? And oh, I got to call this person. So the more information's on our desk at one time, the faster decisions, the more time economic aspects we are. And let's be honest, time's the essence. You can buy everything else in the world. You can't buy more time. So if you can save a couple minutes per patient and make that experience better, why not? Again, just part of the BPH workup here, and measuring the volume. And This is pre-AI bladder scan. We'll be showing you some of the newer stuff, but that was one way we can do PVR, and then measuring the volume. This was a referral to me for a large 60-gram prostate by rectal, measuring 130. So obviously the treatments will be very different in offering BPH surgery based on that volume, and the fact that it protrudes significantly into the bladder. So if it's your first green light case and you have that component of a middle lobe pushing in the bladder, you may not feel as comfortable as doing some other techniques. So again, some food for thought of planning and deciding and decision-making with the patient for the prostate. So again, this was like a 55-year-old gentleman who presented with male LUTS, a significant IPSS score, and his Qmax was only 6. That's a slow flow. Anything under 15 considered slow. This max speed, that's how it's measured for urine for the non-urologist on the call. And he avoided 230 cc's, but his PVR after urinating left is over 500 milliliters. So he's only emptying about less than 30% of his volume. So again, we use the Clarius C3. Here's some of the quality images you could see. Lean, thin gentleman, and you can see the middle lobe. You can see that it was a 65-gram prostate, and it had quite a thickened bladder wall with small little cellulae, not a full diverticula. And then from that point, we took him for BPH outlet surgery and an aquablation. Here he is 1 month after. So again, just to kind of show what we did in terms of surgery and helping explain to our patients. So you can see here the bladder emptying is much better. His on the second image, you can see almost like a defect at the bladder neck, the absence of that middle lobe now, an essential hole in the prostate, almost like a donut. So we were able to get his prostate down to 23 grams, which is a 65% reduction, just helping the patient understand what we just did to him. And then, this ultrasound could help us be not just, radiologists to our patients in some degree, but can it help us deliver the anesthesia? And the answer is yes. So we're able to, and those on the call who do any resume or BPH missed procedures where you want to do a block of the prostate, well, you can do that with this device. The EC7, the endocavity, it's the handheld, and we'll use, the sheath that snaps on. There's one that's dedicated to that. And as you can see, there's on the right, my hand holding the device, my hand pushing the syringe, and right before me, the image. So unlike, you're looking over here, where's the button? You're constantly like a pilot, switching your head gear and reorienting. My eyes are at the surgical site and the camera, everything there in front of me. So I find a little bit more comfortable and certainly more ergonomic. So here's the Civco and the model number. I'm sure we can provide that for those interested after, but that's the model that snaps on a disposable plastic part with all the other components for the block, the sheath for biopsies, what have you. When we do the block, this is something that was one of our papers we published on the periprostatic block, different sites of access, the classic seminal vesicle, so beneath the seminal vesicle, but sometimes you can puncture through the seminal vesicle and treat between the seminal vesicle and the bladder, which is the entry point for the neurovascular bundles as well, and vasculature to the prostate in the transition zone. So I find that's a deeper block for those who are getting a resume. And then certainly the apex, also those doing TURPs will know there's also blood flow coming from that apex. So the nerves follow the arteries. So doing that. So you can see here, in the position, I'm measuring the X times Y times Z. There's even a biopsy line that helps guide your needle placement. You can just, with a finger, just tap, tap. You're not having to spend time on a button. At the very end, you can use a grill at the bottom of the sheet that I helped work with Clarius to build. Just tapping, is the echogenicity normal? Is there a middle lobe? Yes. And so you don't need to sit there and type up your report. It's already automated. You just need to tap buttons, and you can even use Siri Dictate or your other, Android option to just record over your findings and your details. So it not only helps you be a better physician, but also for your clerical work makes it easier. So that's it. So that was our EC block study. We just did a small series. And we looked at visual analog scale. Was it as good for pain control? And those are measures on a scale from 1 to 10. And during the treatment, you could see 5. But hey, how did that do compared to the actual resume study? The Penthrox with Dr. Elterman, he had done an inhaled agent, and our Clarius pilot seemed to be as good, and it's certainly cost economic, not buying additional systemic therapies for the treatment. For those on the call here today who do TERP or green light, sometimes you're training residents and, hey, it looks like a nice channel. Did I get to the capsule? So you can simply place on the probe transrectally or transabdominally and have a look to see how you're doing relative to the surgical capsule and see the defect size that you've created. Again, something else that may help with residents or your own learning curve through these treatments. And also for the post-op, if there's some residual obstruction or so forth, you can pick up clots. Is there residual tissue? And also to see the defect that you've created in the center of the prostate. Here's a little study that looked at, was kind of brought to me, is the C3 as accurate as a transrectal? And we compared the two and also looked at the actual prostate weight for those about 100 men who had radical prostatectomy. We looked at the specimen weight, we looked at the transrectal and the transabdominal. And as you can see that for those prostates, very congruent accuracy across the board with a slight variation between the two. And then the other thing, I guess, as urologists, we pick up a lot of elevated PSA consults, and with it, patients are concerned. They've done their Dr. Google. They think they have prostate cancer. So again, something that helps us identify early on, maybe before we send them for an MRI, which is really I think the standard of care now, outside of extremely high PSAs or evident prostate cancers. But you can pick up with the clarity of this imaging, you can pick up these hypoechoic lesions, which in this case matched up nicely with the MRI, and he had cancer in that hypoechoic area. And just for fun, we threw on the Doppler and saw, is this a vascularized type tumor? And I foresee down the road, a micro ultrasound. I know that Exact View and a few others have, again, a tower setting, and they've done some great data to show its accuracy in prostate cancer detection as good as MRIs with some of the work with Dr. Klotz. So will we see a day where this is the case for handheld as well? It's not too far away. And that's it. I think in the same thing too, for those on the call who do any radical prostatectomy, you're about to cut through the bladder neck. And I've done my fair share of radical prostatectomies, and I always didn't like having to deal with bladder necks with the middle lobe because it requires more reconstruction. It's a tougher anastomosis. So, and the residents are like, I want to do the case. Well, hold on, this may be a tough one. Why? So before we start the case, before prep, I launch this on and say, hey, is there a middle lobe? And, this is a case where there was, and you can see a little bit of a protrusion here as we lighten the grayscale, as we come back to the bladder neck and we move to surgery. And, there's that middle lobe. And we knew that ahead of time. So I'd already asked for the V-lock suture, grab the middle lobe, lift up. So I was prepared. It didn't catch me off guard. Really, if there's one big portion that I think that's the big savior here, is time for me and the patient. So prior to 2000, let's say 15, when I got started with this, this is me and the patient. So we're in the room, we need an ultrasound. What does that mean? I'm going to get a piece of paper, stamp it out, put a sticker on. Sir, you get an ultrasound. He'll spend some time getting his appointment, searching around different clinics. Where do I get my ultrasound? Meet with a technician, not a doctor himself. There's no information. They ask questions. What did you find? I can't tell you. They do the ultrasound, they leave, nothing gained. They don't know what happened. Then a radiology technician will show the images to the radiologist. They'll dictate a report that then gets transcribed. I know some centers, they also have AI, drag and dictate, and then that gets sent by whatever methods, fax or what have you, to the clinic. And then finally, the patient has to come back and make an appointment. And here you are now, if we're lucky, 4 to 8 weeks later, we go over the results together. And you have to yourself as a physician go, who are you? What's the notes? What was our discussion last? Whereas now, seriously, I spend 2 to 3 more minutes. I'd get this ultrasound. I spend some time and I go right to the diagnosis of what we need to do. So time, cost, anxiety, trust, all those things, I think we just become more efficient. Here's some stuff on the AI. Again, I think AI is the buzzword. It's like the hot topic in every conference now, but really, this is going to be, to me, this is where we're at, developing patterns, helping us become better transcriptionists too, making better decisions with real world data. But simply, you click a button, it'll scan for you, it'll pick up your volume, here's a report. And I dream of a day too for like a auto prostate where you pick up the middle lobe, what's the prostate size, what's the bladder wall thickness, maybe an algorithm to say, compared to the last few years, this person is 3 or 2 years away from being in retention. Let's do something now. So signs of deterioration. So I think that may be our cost-effective model globally to help pick that up. So again, really to standardize and democratize the evaluation, maybe the treatment options, we can create these 1-2 page reports, which I'm already doing, which picks up those details. It saves time and potentially for billing, which we had talked about. That's it. I think, and again, the temporal changes that our patients think we know, and we remember their prostate from this. We know that's not a very good tool, especially after 50 grams. It's a bit of a guesswork. So again, I think POCUS allows us to be more accurate, deliver timelier care. I just think of the whole, at the end of the day, my mom used to tell me, people will forget what you told them, people forget what you did to them, but they'll always remember how you made them feel. So if you can change that experience and make that like that moment something memorable, I mean, isn't that what we went to medicine for, to help touch and help other people? And really, this is a true contact type of care to our patients. So, and again, it's small, it's portable, it connects to pretty much any phone that's out in the market. It's HIPAA secure, it's low cost relative to the cost of what even a bladder scan costs. You know, I think in the future too, I think this whole idea of remote healthcare. So will I dream to see of a day that something, this crystal will be on the tip of my finger, or maybe that of a patient, so that they can go to their grocery store. Hey, let me just check my carotid and see if I've got some plaques, or has my prostate size, or part of a chair that we sit down. I mean, the sky's the limit here. But right now, I think in 2024, to me, at least my practice, this is the standard of care. I just think it takes me beyond God-given 5 senses. And certainly, as we know, as urologists, this is, you know, medical students sometimes ask, how do you know? Why is it 40 grams? And I'm like, we don't know. It's either a tangerine, an orange, or maybe a grapefruit. And we don't know the y-axis, and we don't know if there's a middle lobe. And so much is more than that. And for that, I just think that, you know, the Clarius system has really helped me in my practice. So thank you for listening. And I guess we'll move it on to Shelley with the next steps.